I'm Dr. Mark Gold, and this is the Gold Standard. Well, it's my pleasure to introduce Dr. Sarah Vinson, who is just a fantastic colleague of mine, but also a mentee, someone who I've known just since she graduated college. So, welcome.
Thank you so much for having me.
Oh, you're welcome. I thought we'd go through like your path to get to be chairman because I think you're the youngest chairman in the United States. Do you think you're the youngest?
I don't think I'm the youngest anymore, maybe when I started, but I'm 3 years in now, Dr. Gold. 3 years in.
Oh, all right. So you were the youngest. So just when you came to the University of Florida to interview, I was on admissions, and then somehow we met while you were there as a student. And I think you came from Florida A&M, but I could
That's
be,
right.
it's right. So just like, how was that being a pre-med there, and how did the Florida interviews go, and like what happened early in the career?
Yeah, so I came into medical school thinking I was going to be a pediatrician. And actually, there was a lecture that Dr. Gold did about the neurobiology of addiction that was eye-opening to say the least. I grew up in rural Northwest Florida, and where I grew up, people with addiction issues ended up in the criminal justice system. I really didn't have a concept of addiction treatment or addiction as a field of medicine until I was in medical school.
Huh.
And it was that exposure and understanding how much this mattered to my community and how much there needed to be access and education related to these things that really got me interested in psychiatry. And so, even though I didn't ultimately end up doing an addiction fellowship, I did do a child and adolescent fellowship and a forensic fellowship, and have continued to do that work and grow in the field and learn more and more since.
Well, you were an inspiration to everyone, and there was like a fight over you, and like, would you go into pediatrics? I remember that with Donna, and I kept being, hopefully, I was a gentleman about it. I mean, it was clear that you could rise rapidly because you had an interest, you're brilliant, and this, the field was really just starting. But I'm happy to have you in child and adolescent psychiatry and as a chairman. And I hope, and I know everyone really at UF is so proud of you. So you got through UF, and then for a person from rural, what'd you say, Northwest Florida?
Rural,
Uh,
I say it's the functionally Alabama part of Florida.
yeah, I mean,
Yeah.
you then somehow you went to Harvard for your internship and residency. Like,
Yes.
was that like crazy? Like, how could you be so brave?
Well, I ran track in high school, was actually a state finalist in the 400, right? And a lot of times in practice, they would have you run with the boys, right? If you were one of the faster girls, because you needed to run with people who would challenge you. And I knew that my goal was always to come back to the Southeast and serve in this region because it is underserved. But I wanted to, run with the big people, right? And I remember you telling me this, and I actually repeat this to students to this day. You only train once, right? And so I wanted to train in the best environment that would give me the greatest tools possible as the foundation of my career. And at your encouragement and with your ridiculously nice letters, was able to match up there and had the opportunity to train directly under Dr. Judith Herman and learn about complex trauma, which has been so formative in my clinical work, my consulting work, my writing, my teaching, and really couldn't have asked for a better training experience.
So that was amazing. And then you came back to Emory and did forensic,
Yeah,
right?
so did child and forensic at Emory, which was nice in that it allowed me to learn about the systems here, since I've ended up staying in Georgia. Because I had such a fabulous experience at Florida A&M at an HBCU, my goal was to be faculty at an HBCU medical school, and Morehouse School of Medicine is here. So came down to Atlanta, always with, Morehouse in the crosshairs, and have been at Morehouse School of Medicine in some capacity my entire career, but was always part-time until I became chair, curve. And so it allowed me to wear an entrepreneur hat, learn about business a little bit, but before I entered into the chair role.
Yeah, that's amazing. So just for people who don't know much about Morehouse's Department of Psychiatry, could you just give like a quick overview? So, people might call you and send you a case or something. I don't know.
Yeah, so our department is over 40 years old, but we are a young medical school. So we just celebrated our 50th anniversary this year, or it's a year-long celebration. And we are a community-based medical school. So that means what we do is in collaboration with community-based partners, largely people who take care of folks who are uninsured or publicly insured. We don't have our own hospital. Our main hospital site is Grady Memorial Hospital, which is the only safety net hospital in the city of Atlanta. And our department actually has a variety of partnerships with community-based medical centers, Department of Juvenile Justice, the state, Department of Behavioral Health and Developmental Disabilities. And we have a mix of child psychiatrists, adult, a couple of CL folks, a couple of addiction people. And in the past 3 years, we've really expanded our forensic footprint as well, with me coming on board as chair.
So that's amazing. And you started your own group in private practice, and we've been able to keep that up and grow it, or what's the story there?
Yeah, so I have a great dean, Dr. Adrian Tyndall, who, when he was trying to recruit me for this chair position, knew that I had this business. And he said, as long as you get the job done, go, it's a pre-existing entity. And so I've had a lot of support around being able to continue that, and I've gotten the job done as chair. But that company really came about because there is not a lot of diversity in the forensic mental health space. And I was at the point where I was getting so many calls, I couldn't take them all. And there was a recognition that part of why I was getting these calls is because I have this culturally and structurally informed lens that is not prevalent in the field. And so the company was a way of me being able to give people access, exposure, training opportunities, and the ability to learn this work. And so I have recruited a team of all Black and Brown mental health clinicians that are interdisciplinary, that I have in some cases trained to do the work, and in some cases just supported people who are already forensically trained. And we've done cases and are doing cases across the country, and I have an amazing staff. And so it all works out.
So give me a couple of ideas of the kind of cases that you might be called to evaluate.
Oh man. So it runs the gamut. So since I'm child trained, and actually half of our clinicians are child trained, we get cases related to child custody or parental fitness or school discrimination and its impact on children. On the criminal side, we may get cases of youth who are being considered for adult court. We do a lot of death penalty work, actually, people who are either facing the death penalty or have been sentenced to it and are now in the appeals process. And really our role in those cases is helping the court understand not just what the person did, but why and the circumstances that led up to the actions, because so often trauma, intellectual disability, mental health issues that were untreated, unaddressed were a key part of that picture.
And then what about treatment? Does the group provide treatment in addition?
So in the forensic space, we have to keep things separate so that we don't, act as advocates, so to speak. But I have a private practice that I had to largely shutter once I became chair because there's only so many hours in a day. But I do have a handful of psychotherapy patients that I have had for years that, I'm not letting go of. So.
Well, it looks like you would get too much joy out of it.
Yeah.
That's awesome. So when you talk about like a whole group of Black and brown psychiatrists, is it like you feel like you're swimming against the tide right now, or are you waiting for the next wave?
Well, it's we have not had a decrease in our demand, right? And I think in some ways because of the people who are being targeted right now, frankly, we may see an increased demand, paradoxically. And our docs, like they're really good. I mean, these folks have trained at Yale and Penn and Harvard, and so what we found too is that sometimes even in cases with white defendants, the fact that we think about structure and social determinants in this way is instructive, right? Because
Definitely.
regardless of racial background, most people who end up facing criminal charges are marginalized in some way, right? And so that lens is quite useful across the board, is what attorneys and legal teams are beginning to find out.
Yeah, and your work at Harvard wasn't exclusively among Black clients, and
Right.
the trauma, like, what would you think? I mean, if you think about the role of trauma and early life experiences in psychiatric problems and behavioral problems, I mean, why wouldn't your experts' opinions generalize across every kind of person?
Yeah. And, that's part of what's so helpful about being child trained and having the chance to train under Dr. Herman when I was in general psych residency. Even for the adult cases, that developmental period was always so critical. And so, that lens informs everything we do, regardless of the age of, the defendant.
Yeah, I always found you to be like a Renaissance psychiatrist, and as you know, I use you with your permission as to peer review my own work. And you've helped me a lot. I mean, I was thinking about it this morning when we were doing the piece on cannabis, and you said, "Don't you realize that cannabis may be the only quote medicine unquote that my kids have access to because they can't see a psychiatrist, they can't get an SSRI, they can't get psychotherapy, but they can get cannabis from their grandmother." I think you said something almost exactly like that.
Yeah, it was the aunt. I think I had recently seen a paper
Auntie,
that
the
yeah, the
auntie.
aunt had it. The aunt had a
That's
dime
it.
bag. Yeah.
Yeah. So just could you just explain that to the audience? Because it was startling for me to think that that's really what we're dealing with.
Yeah, I mean it's hard sometimes, right? Once you get into these administrative roles to hold on to clinical care, but it's so critical because it informs your perspective. And, even if I share certain aspects of people's identity, there are things that people are experiencing now, challenges with access to care, that it's helpful to be kind of close to the
Sure.
problem in one way or another when I'm personally in a position of privilege in a lot of ways now. And what I see, whether it's as a forensic consultant who's looking back at people's records, or as someone who is in public sector clinics or covering for them, is that access is so hard. Trauma informed, culturally informed, timely access that is tailored to the needs of working families. It's really difficult. And so what I often see and saw as the default when I worked at juvenile justice is that people have been self-medicating for years before they get to us. And marijuana, for a number of reasons, is just perceived as less dangerous to youth. And it would be striking when I was at juvenile justice how many of them, when I asked about alcohol, like, "Oh no, I don't mess with that." But marijuana didn't even register to them as a drug, and that was because, in large part, it's normalized, in their community or in their family, and they know a lot of people who have smoked a lot of weed who haven't seemed to have some terrible thing happen,
Sure.
right?
Sure.
So you trying to give them education about all that could go wrong, in some ways, for a lot of them, is going to fly against their life experience. And so it just, there's always that way that you have to merge what you're hearing and reading and research with what you're seeing on the front lines, and thinking about how you put those things together in a way that is, therapeutic or helpful for people.
Yeah, that's great. So the other, I mean, you gave me a lot of advice on thinking about race and trauma and male versus female in ADHD. And you might be the U.S. expert on that in that area, but maybe share a little wisdom with us. How do we understand ADHD in your community?
Yeah, so ADHD is something, of course it's a real thing. But what you'll often see is that ADHD is kind of like a gateway diagnosis. So it's one that is more palatable, perhaps it's less traumatizing or stigmatizing. Sometimes it's very hard for families and caregivers to concede or acknowledge that things they expose their children to are resulting in symptoms. And teachers are very familiar with ADHD. They got the Vanderbilts floating around everywhere. And so, again, both as a clinician and as someone who ends up looking at records from throughout people's childhood as they enter into adulthood or are already there, you often see where if something's wrong, there's an ADHD label somewhere, right? But what you can see a lot of is that when it comes to youth who are exposed to neighborhood violence, race-based traumas, traumas within the home, those symptoms have actually been mislabeled as ADHD when they're really manifestations of trauma. And so we have this situation where in some ways there's overdiagnosis, but in others, because of the access issues, there's underdiagnosis in marginalized communities. And so it can be tricky and it can be both and. But what I see a lot of is that label of ADHD being thrown on anxiety, trauma and stressor related disorders, and those other issues not being addressed or treated or seen.
Well, I mean, it's hard to even know where to start with that. It's a huge issue. You fall behind in school, and it's very hard to catch up.
Yeah.
Um,
And part of the conversations that I have, with Black families in particular, is just the reality that society does not give their children as much room for error. Right. And so part of our informed consent process sometimes is talking about, what it means for your child in this society not to succeed academically or to be expelled and potentially exposed to police officers in a hyper, police community. And you wish that it wasn't different, but it is in terms of the leeway society gives them, how childlike society sees them as. And that is something that, just has to inform how we think about, protecting and serving these youth and their families.
so you would feel that's the case in Atlanta as well as it would be in Northwest, the Panhandle. Is it really? It's the same in Atlanta?
Well, Atlanta is a really interesting city because, it's actually a poster child for redlining. And it
Huh.
is one of the cities that has the lowest upward mobility for people who are born poor here.
Huh.
So what you have here is a lot of Black professionals who are transplants like me. And that's kind of the face of Black Atlanta, so to speak. But if you are born poor in Atlanta, you are likely to be in a hyper segregated, marginalized community and have increased risk related to hyper policing and those inadequate resources.
You would think would be so empowering to have a Morehouse with Dean Adrian Tyndall and you and all the other group that you could kind of see that there's a pathway. But what you're saying is you can't really see that from within Atlanta. You have to enter it from somewhere else.
Yeah, and I will say the school, certainly does have outreach programs, partnerships in the community, and that is something that we are always thinking about are not just pipelines, but pathways into professional fields and into medicine. But when you are working against decades and decades of redlining policies and socioeconomic marginalization, it's an uphill battle. And, Atlanta is blue dot in a very red state. And so there are the things that come with that as well in terms of resource allocation and narratives and all of those things. And so I do think that it absolutely makes a difference that the AUC schools and Morehouse School of Medicine are here. But the what you're up against and how entrenched it is really remarkable.
So when you think about looking at race and various psychiatric problems, I mean, in my field, they've always said that African Americans use less drugs than other populations. And do they like does the cannabis situation mean that there's more psychosis? I mean, or more depression, like or more drug-induced disease, or I mean, just trying to understand how that impacts public health. The two things. I got the trauma. There's no treatment, so it goes and festers and only gets worse.
Yeah, and people, they find sometimes they're able to find meaning and healing apart from the mental health care system as we traditionally define it and think of
Mhm.
it. And I think often when they do, that is how they get help or find healing. So I think that's always important to lift up. But the the issue of the diagnosis of psychosis and schizophrenia in Black people, trauma and substance use, I think is one that really is intertwined. When I was at juvenile justice, I did a lot of deprescribing of children who had been diagnosed with bipolar or psychosis. And what really was happening was they had re-experiencing symptoms that were mischaracterized as psychotic symptoms. And some of their numbing and things like that associated with their trauma was thought of as negative symptoms. And so and again, this is observational. I wish I had a study to back it up, but my observations are that in a mental health care system that often does not think about, account for, ask about traumas that are specific to marginalized populations or race-based traumas, we miss it. And so we see the symptoms that have resulted from that trauma and put it in a box that makes sense based on the DSM, because the DSM doesn't give us a box for race-based traumas or traumas that are part of your lived experience as long as you've been alive and will continue to be. And so they get labeled these other things that may not be accurate. And so I think in some cases, yes, you may be seeing a cannabis-induced psychosis. In other cases, you may be seeing agitation, cannabis use, and a healthcare system that we know overdiagnoses Black people with psychosis kind of coming all together.
After talking to you for this period of time, I don't know if I should ever evaluate another Black person psychiatrically without your help. Like, I wouldn't even know all the questions that you think are the minimal to ask. Like, is there a crib sheet for the white psychiatrist that wants to do a good job?
Well, one of the things that I recommend to people is learn about the communities that your patients are living in, right? Even if they don't come in saying, I've witnessed gun violence in my neighborhood, right? If you can look at the crime reports from their block and see that there were 6 murders in the past 9 months, doesn't matter if they report it or not, right? Like, that this is part of their lived experience. And so just being curious about and looking up at, and it's always, very available to people. One of the things that I think is important to highlight is that sometimes people will test folks out to see if they're safe, right? So you're probably not going to get all of someone's trauma history, certainly not all of someone's race-based trauma history in the first appointment. But what you may get is them mentioning some aspect of it and seeing how you respond. And what I've seen in some of my, well-meaning white colleagues is that they say, oh, it wasn't that bad, or, oh, you made it through it. And that actually is experienced as quite invalidating, right? So are you able to hear it, to sit with the experiences that person associated with it, and not respond in a way that is about kind of diffusing the situation or trying to make yourself more comfortable. So really showing, just like when we talk about things that may be harder for people to discuss, like sexual-based traumas or identity or things like that, that really showing that this is a safe space where these things are fair, is something that's important, and understanding that it is often going to take time.
What are the general views in the community about psychiatrists? I mean, when I kind of remember when you came in, to UF that you had some negative thoughts about psychiatry in general as a medical specialty, not it was like, is that real or is versus pediatrics? Is that like in Atlanta? Would that be the case? So people do they, what do they think about psychiatrists and what do they think about you as a psychiatrist? I mean, both I think are fair questions.
Yeah, well, I think there's definitely some shifting happening in the community as it relates to mental health and discussions around it, right? You have NBA players and all
Right.
kinds of folks that are talking about their therapists and in a way that I certainly don't remember growing up. And when I went to medical school, I just hadn't had exposure to psychiatry. So my idea of it was literally, rich white people complaining about their mom on a couch, which had no like correlation to my.
That was my whole training. Sorry.
But yeah, and so I do think that things are shifting. I still think, if you ask my parents' generation who are, the baby boomers, you may get a different answer than if you ask my medical students or my grad students I mentor, right? So there's some generational shifts, but so much of it is showing up and doing it in an authentic way, right? So whatever they think of as a psychiatrist, it's usually not me when I walk into the room, right? And so, me and my colleagues that show up, as we show up in our Ankara prints and our natural hair and unapologetically about serving our communities, I think is helping to also, change how people see the field or what it can be.
That's great. Like, is there a mecca for Black psychiatry? I mean, if it's not Atlanta, is it New York or Boston? Like, where is like the best place for if you needed help? Where would it be?
I mean, I would guess we have the most here in Atlanta. My department alone has 25. Um, but even with that, it's a lot of times people are still full, right? Like it's
Of
even
course.
here, it's never enough. But I do think that probably Atlanta, Dallas, Houston, maybe DC, but it's never enough.
So, like, what are the hot issues in your field? Like, what should I know about as like an emerging issues? One, two, three.
In the field of psychiatry as a whole,
Yes,
or
you feel the psychiatry, Black psychiatry, if there's such a thing. It said hood feminism I'm looking at, but I mean,
oh, great book.
why is it a great book?
So, it really breaks down how our idea of feminism is really centered on whiteness and comes from a white perspective, and that if we're really talking about uplifting women, we have to be very intentional about doing that across the board, and taking a critical lens to feminism as it is often by default, white centered.
Cool.
Yeah.
So what am I missing? What are the top three issues that I should know about when I'm thinking about psychiatry and Black people?
So I think, one, trauma, trauma and identity. So maybe that's one and two. Um, Intergenerational trauma has always been an issue, but what we're seeing with this, with recent events, right, are situations where, what I'm concerned about is people being labeled with anxiety disorders when their reactions are really fear-based, right?
Mhm.
It is a reasonable response to the reality that people are facing right now. And if you're a group that has been historically marginalized as a society shows more authoritarian tendencies, that is going to have a different kind of hit for you. And I'm hoping that we can be thoughtful about that and not just label people with anxiety disorders and put them on SSRIs and really think about how we support communities who are in genuine fear at this point. Identity is also critically important. The feminism issue of centering whiteness. We do the same thing in the mental health field, in the DSM, in a lot of the theories that we learn from. And what we know is that having a positive racial identity, if you're a part of a marginalized group is really protective. And I can tell you it was certainly very protective for me growing up in Pace, Florida, and navigating some of the spaces where I have. And we just don't talk about that in psychiatry nearly as much as we should. But I have done work with therapy patients where so much of the progress was because we were able to talk about racial identity and work through those things. And I was able to bring in things like readings by James Baldwin about what it means to be a Black person navigating the society. And that is healing and important for people and shouldn't be overlooked. And then I guess the third thing I would say is just thinking about how access not only to care, but also exposure to adverse social determinants of health is being shaped by some of the policy changes that are happening, right? So often as psychiatrists, we end up doing tertiary care, right? Mm-hmm. Something is wrong and has been wrong for a long time before people get to us. And we can look back and see these disruptions in housing, in educational opportunity, in occupational opportunity, put people on this road. And so just thinking about how when you have changes in resources for people, the communities that are already marginalized are going to be hit harder. And so that's something that I'm thinking about a lot too, not just, everybody's talking about Medicaid and all of these things, but thinking about how the social determinants of health and the adverse social determinants of health are being shaped by some of the decisions that are being made currently.
So start with the last first. What are you the most worried about, the social determinants of health?
Oh,
Change.
man.
I can say, I was concerned that some of the CDC vaccine hesitancy grants were eliminated. I think it's important to know why people won't be vaccinated or how they feel about vaccination. And it's one, you could invent the polio vaccine, which I remember very well when it occurred. But if no one would have taken it, wouldn't do you any good. It's kind of like naltrexone. You could say it's the Ozempic for alcohol, but I would tell you that Herb Cleaver and I gave it to people with alcohol use disorder and opioid use disorder in 1975, and it's still not prescribed. Yeah. So we'd like to know, why won't alcoholics or people with opioid use disorders take medicines that might make them immune to their disease? I mean, these are things that I'm concerned about, but I'm not living in your community. What are you concerned about?
Yeah, but that gets to the issue of narratives and how much they matter in terms of shaping behaviors. And I think that when it comes to the social determinants, as a child psychiatrist, of course, I am thinking about education and Medicaid a lot, given some of the discussion happening. And as someone who's in the Southeast, right? So when you look at funding for those things, what that is relative to what the state can absorb, right? I'm on a board of an organization in California, and California has a state income tax base where they can weather some things at the federal level that, maybe your Alabamas and Georgias can't in the same way. Mm-hmm. So, that is something that is on my mind as a provider. But, fundamentally, people need to feel safe. And if people don't feel safe, anything you're asking them to do, whether that's asking a student to study and read in class or asking someone to go to work and operate at their highest capacity, is always going to be undermined. And so, some of what is happening now, understandably, I think is really making it hard for people to feel like they know what's coming next, or to feel as if they can predict what's coming next or protect themselves from it. And that is something we have to keep in mind, because if you don't feel safe,
it makes you feel powerless.
Yeah.
Everything's outside of your control. It's just for psychiatrists. Is there some pearls that they should always try to do? You gave me one, which was, it's important to understand the community where your patient lives in terms of their exposure to traumatic events, not only just to ask them, but to know what's happening. Do you have any other things that we should do? All the white psychiatrists listening to you?
Let's see. I think always being mindful of the gap between lived experiences, right? And um, making it a point to come back to that. And the people who go into medicine, regardless of race, usually are privileged in some way, right? And so always making it a point to take a step back and think about how they're being in the world, how systems or structures respond to them is different than you, or different than what you would think based on your own lived experiences. Um, Anything I would say is don't be afraid to always keep learning and to be curious, right? Don't necessarily expect your Black and brown colleagues to like do the labor for you and teach you, right? There are books, there are podcasts, there are things that you can do to be um, educated on these issues of inequity and race and mental health. And, understand that you may make mistakes, but you do want to make sure that people understand that this is fair game and that you're open to these problems. And then also one thing I would encourage people to do is not only thinking about it as it relates to interactions with patients, but interactions with your care teams, with the other people that are around the table. And if you don't have diverse voices around the table, how do you get them there? Because that is really critical too, right? There are people who could be from your community or from some of the communities that your patients are from, who could inform what you're doing much better than I could sitting in Atlanta. And what I often find both in medicine, but also in some of the legal work I do, is that the teams just aren't representative at all. So if you're in a position as an administrator, how do you address that? And sometimes having people who are peers, for example,
Hmm.
can be a way of having greater socioeconomic and racial diversity on your team than if you only have, MDs and PhDs there.
Tell me about your book. Is it a bestseller among academics? How has it been reviewed and received since it's come out?
Yeah, so my book, Social Injustice and Mental Health, that I co-edited with Dr. Ruth Shim, has been very well received, very well reviewed. And we knew, right, that we were talking about things that might make some people uncomfortable, that might come under fire. And so as we were going through the editing process, we talked about how this book needed to be unimpeachable. And I think we pulled that off. It is really well done. And we had a wonderful group of chapter authors and collaborators. And what we do is really explore certain systems. So the school system, the carceral system, or the criminal justice system, for some examples, and then certain diagnoses like personality disorder, schizophrenia, and look at this interplay of society, injustice in society, and how that influences the manifestations of mental health and our system's response to it. And at the end of each chapter are reflection questions for the reader. And we are writing, of course, with the mental health audience in mind, but it's a book that has been picked up for book clubs and group readings
Oh,
by
wow,
policymakers in major cities, as well as, the typical kind of academic curricula.
that's great. So, do you have plans for a new book too, or like, we going to see you on Oprah or what?
Funny you ask about a new book. APA has been APA Publishing published Social Injustice and Mental Health, and I think on the strength of that book, they've actually been reaching out to me about another book. And what I have in mind is something that is related to forensic mental health specifically, but
That's
that
great.
brings that culturally and structurally informed, social justice informed lens to thinking about how we go about as forensic mental health practitioners as well.
Super. What do you do in your spare time to manage your own, stress and anxiety, if you have any?
Yeah, so my residents, my medical students, my mentees, they can all tell you this verbatim. I sleep 7 hours a night. I vacation every quarter. I work out 5 days a week, and I get massages twice a month. And so I really do practice and demonstrate and model self-care. If it's not obvious, I love what I do, but I want to do it sustainably, right?
Sure.
And all of those things are critical to being able to do that.
Well, I mean, you gave us a lot to think about. Also, I mean, it's obvious, I think, to everyone by now that you're just like the most optimistic, well-meaning, and dynamic person that they've probably seen. I mean, with all the things that you have to worry about and the way you think about how the world is structured, and like, how do you do that? Like, how do you remain so upbeat, enthusiastic, and positive, and caring and loving? How do you do it?
Well, I work with some amazing, inspiring people. We had our department retreat for Morehouse School of Medicine, Department of Psychiatry and Behavioral Sciences last Friday, and we have our new hires do a presentation about their why. And it was like going to church. Like I tell you, like it's just amazing to hear what has brought people to this work, what keeps them engaged with it, and to have the opportunity to encourage and create community and provide, support for folks like this. It really is an honor and a privilege. And so, yes, we are up against a lot, but we see how what we're doing is making a difference with the people we serve. And so I serve them, and I report to the dean, but I work for my faculty and my staff. And so getting to support them and the amazing work they're doing is just a treat.
Well, you're a wonder, and I appreciate you very much and always have. But you've really made everyone so proud and excited and optimistic about the future. Thank you.
Thank you, Dr. Gold.